So this is a 55-year-old male patient who came to my clinic with history of RTA. That is, while traveling in an auto, it was hit by a bus. So that is a road traffic accident, high velocity accident, and he sustained a distal femur fracture. So the bone that forms knee joint just above it, there is a fracture. That is the longest bone of the body here at the knee. So that is called distal femur fracture. Like you can see over here, this is a fracture with complete comminution and overriding. This is the most comminuted part. So this is distal femur fracture. He had this plating done maybe 3 years back in outside hospital. That plate is broken with all the screws broken inside, but we chose not to remove it now because we don't want to disturb that, and first we want to treat this. After that we'll see about this. So distal femur fracture, this is a high velocity fracture, so we chose to plate it. That is open rejection internal fixation with plate and screws. So the implant of choice, as I've told you, it is stainless steel for the patient, the surgical steel. So what we have done today is we have fixed the fracture like this. This is the fracture, distal femur, that we have fixed with multiple cancellous locking screws distally, and proximally this is the most comminuted part. Here we have applied screws. This is a 9-hole plate. So this is how it was. This was the most comminuted part. After fixing the entire bone, we came to this comminuted part and we fixed it with 2 cortical screws. After a lot of struggle, we fixed it with 2 cortical screws like this. 2 cortical screws, we fixed it. We had to do an anteroposterior fixation also with a lag screw, but we chose not to do it because it was the bone which was there anteriorly was completely comminuted. So we chose not to fix it and leave it so that it will unite by itself. We didn't disturb the blood supply or periosteum lining or muscle attachments of the anteroposterior part. We left it intact so that it will heal by itself. And superiorly, we fixed it this way. So this is the distal femur fracture. The patient's implant of choice was stainless steel, so we had to do stainless steel, or we can do this with a titanium plate also with titanium screws. The only advantage is it is MRI compatible and it is almost equivalent to bone. All the characteristics of titanium are equivalent to bone. So people choose titanium and it's a little costly. So for this patient, the choice was stainless steel. So this is how we fix a distal femur fracture. So this is a case of distal femur fracture, highly comminuted, and it was closed, not open fracture. It was a closed fracture, RTA, and patient was on Spin 150 mg. So we had to stop the surgery for 5 days at least, as per our cardiologist and anesthetist opinion. They have suggested us to do a surgery for at least 5 days. And these 5 days he has to stop the blood thinner, that is Ecosprin 150 mg. In these 5 days we managed conservatively with just a knee brace, long knee brace, and ice pack locally to reduce the inflammation, to reduce the pain, to reduce the swelling. After 5 days we took him off for surgery, and this is what we have done. The plate of choice for him, according to the patient chose stainless steel, SS. So surgical steel was the choice. And this is what we have done. This is the fracture which we have reduced, and we have reduced the distal femur anatomically. This is the femur condyle which you can see, and this is a 1, 2, 3, 4, 5, 6, 7, 8, 9-hole plate, 9-hole distal femur locking plate. So applied a tonic way very highly near the groin so that there is very less bleeding during surgery. We have finished the surgery within 60 minutes. That is different because this is an old age patient. So we have to conserve and do minimally invasive surgery as much as possible. So the fracture is completely comminuted with multiple fragments. So we had to open it completely to fix each fragment anatomically to the main bones, long bone, and put screws through the plate into the fractured bone and reduce them anatomically. So we had to open knee joint because there was distal femur intercondylar fracture also with the extension into the joint. So we had to reduce it anatomically and put a plate and screws through the condyles to reduce the condyles. And anteroposterior screw had to be put, but we chose not to apply an anteroposterior lag screw because the anteroposterior fragment is comminuted. So we cannot put multiple screws. So we have left it so that it will unite by itself without disrupting the blood supply to the anteroposterior fragment, without removing the periosteum, with leaving the soft tissue intact to it so that it will have blood supply and it will unite anatomically. So this is what we have done today, distal femoral fracture fixation.